All right, everyone, welcome back. I hope you had a rejuvenating and kind of stretched out break doing some yoga. We're going to transition into our second keynote by Dr. Walkman, which will be focused on more of the clinical care of families impacted by substance use. Now, to place that into context, I wanted to share with you our most recent data for our state's CHoSEN QIC efforts. And so I'll be presenting data as recent as this first quarter of 2021. And so in this data presentation, you'll see reflected about 1,100 opioid-exposed newborns with data entered from the second quarter of 2017 till present. And Blair Weichel will be horrified that I've done this, but I would like to acknowledge Blair Weichel, who has really been a tremendous asset to our team. She is our quality improvement specialist, as well as our data analyst for CHoSEN QIC, as well as our section of neonatology, and is really with her help and leadership that these data reports are even in existence. And so as you all well know, our quality improvement collaborative has been focused on helping to improve the hospital-based care of substance-exposed newborns and optimizing their discharge home. Our primary drivers have focused on increasing and improving participation of hospitals in our state, which in fact has expanded to the Rocky Mountain region. We wanted to reduce postnatal opiate exposure to opiates really through improving non-farm care, increasing use of mother's own milk, and then adopting the Eat, Sleep, Console assessment tool. We wanted to increase family involvement and then optimize that discharge process. So shown here are the total number of opiate-exposed newborns reported by quarter, and I share with you because that in this most recent quarter, we've had a significant drop-off in the total number of OENs, and I wish this could be attributed to that, in fact, we have fewer number of opioid-exposed newborns in our state, and wouldn't that be wonderful? And I think that's not really the case, and as we've heard several times today, the use of perinatal substance use is in fact been increasing during this COVID time. And so I think this reflects perhaps the limited bandwidth as well as competing interests that hospital teams have in perhaps entering this data. And so for hospitals that are participating today, I really encourage you to get that data in, and we'll be sure to get your quarterly reports back to you. Shown here is some limited sociodemographic information about the mothers that are captured in our data system. We can see that nearly 90% are insured by Medicaid. For maternal race, 2/3 are listed as white. And we have about 60% being non-Hispanic, and then about 29% being Hispanic. What I'd like to highlight here is missingness. So shown in gray for both race and ethnicity is missing data. And if we truly are focused on improving disparities in maternal and infant outcomes, we've got to do better on our data collection side of things. So shown here is our process control chart for one of our primary outcomes, which is average length of stay for opioid-exposed newborns. And this is limited to infants that are 35 weeks or greater, whose length of stay is not affected by any other diagnosis. And you can see that since 2017, we have sustained our decline. We initially started off at about 2 weeks and have come down to a little more than a week. We were concerned during the COVID period as hospitals had competing interests, visitation restrictions, and the dissolution really and suspension of the Cuddler program, whether or not the trend was going to be more U-shaped recently. It seems to be leveling off, and we'll have to continue to watch this closely. We've stratified this data by Hispanic and non-Hispanic ethnicity. As you all well know, the Colorado birthing population is not very diverse in race, but we do have a substantial Hispanic population that is in fact growing. And so we stratified our outcome by Hispanic ethnicity and see that in fact there are significant differences. And I'll bring your attention to the last 2 quarters, where for Hispanic mothers, their infant's length of stay is anywhere from 11 to about 15 days. And then for our non-Hispanic mothers, about 5 to 7 days. And so it'll be real important to take a deeper dive and understand what are the other factors that are impacting the care stratified by ethnicity. Here we see for the entire cohort, the percentage of opioid-exposed newborns that receive pharmacologic treatment. At the start of our collaborative, we on average had about 60% receiving treatment, and we've sustained our improvement here, where about 25% of our opioid-exposed newborns are receiving pharmacologic therapy. Now, among those that are requiring pharm therapy, their length of stay is shown here. And so when we first started, we were close to about 3 weeks for birth hospitalization, and we had reached a low of about 8 to 10 days. And then most recently, again, unclear if this is directly COVID associated, we've seen increases, and now we're hovering near the 2-week mark. Again, we've stratified this by Hispanic ethnicity. This is not looking at length of stay, but looking at the percentage of opioid-exposed newborns that have received pharmacologic therapy. And again, interestingly, we see a disparity where our Hispanic infants, 40% received pharmacologic therapy compared to our non-Hispanic, where it was 20%. So a twofold difference that certainly will require greater attention. One of our key drivers is really focused on improving provision of mother's own milk. And so we also recognize that not all mothers may be able to provide their own milk, and therefore we've had guidelines in place to offer some guidance to hospitals about which mothers may be eligible to provide their own milk. So here, this is the percentage of opioid-exposed newborns who are eligible to receive their mother's own milk, as well as being discharged to biologic parents. And then you can see that we've been hovering at around 40 to 50% of our cohort of our babies are actually eligible. And so what this highlights to me is that if we think about those eligibility criteria, much of it is rooted in maternal engagement in substance use services, or for instance, in issues of marijuana, that there's been abstinence for about 2 weeks prior to initiation of breastfeeding. And so this tells me that the majority of our mothers are not actually in therapy, and that there, in fact, are other barriers that our families are facing. Now, as shown here are among infants who are eligible to receive mother's own milk, how many actually do. And so prior to this last quarter, Colorado is a very breastfeeding state with the highest breastfeeding rates, and this even applied to our opioid-exposed newborn population, and we were hovering near 90% of OEMs receiving their mother's own milk if eligible. Now, in this last quarter, this number of 20% is not only outside of the confidence interval, but is just shocking. And I highlighted earlier that we have fewer babies being entered into the data system, and so we will really need to look at this more closely. Is this number because mothers are not being encouraged to provide their own breast milk? Are there other barriers that have been put into place during this COVID time for mothers to provide their own milk? So certainly we'll need to follow this closely. Again, we've stratified by Hispanic ethnicity. And so this looks at the percentage of eligible OEMs who received mother's breast milk. And here we see that in the most recent quarter, both 50% of Hispanic infants as well as non-Hispanic infants are receiving mother's own milk. There's a fair amount of movement in these estimates because of small numbers. But, our goal for equity is not that we bring everybody down. The goal is that we all improve, but that for groups that need greater assistance to improve at a rate to match that of the majority, then we need to think about those care processes. So the fact that both Hispanic and non-Hispanic are at 50, yes, they're at the same 50%, but that was not the goal. The goal was that everybody got better over time. Now, we also focus on that optimal discharge process, and here we see the percentage of OEMs who received a referral to early intervention. For a period of time, we're seeing good increases, where at the start, we were about 20% of our infants had a referral in place at the time of discharge. We got up to about 50% at the end of 2019 and have had a lot more movement over the past year, and most recently at about 30%. So again, highlights that we do have to focus on this period of transition more closely. And again, as I've said many times, in Colorado, prenatal substance exposure does not automatically qualify you to receive early intervention services, but for a referral, the state is mandated to at least do an evaluation, and we think that that is an important piece of the discharge process. Here we see the percentage of OENs whose mothers received any sort of prenatal counseling around postnatal care of opioid-exposed newborns, and this is still where we struggle a tremendous amount. Hence, our emphasis on prenatal engagement during this next year. And so subpar on many levels, and then in the last quarter, none. Here we see whether or not the percentage of OENs received a warm handoff to their outpatient provider. Again, we were seeing some improvements at the end of 2019, albeit still far from optimal, and then most recently, perhaps a decrement. And so the engagement of the outpatient community and really the inclusion of community providers in our development and provision of plans of safe care will be essential, and you'll hear much more about that later on. And then importantly, while quantitative data is certainly important, we know that qualitative data offers a much deeper perspective on the experience of parents as well as providers. And shown here are some quotes from families impacted by substance use during their birth hospitalization. And I'm just going to read off just a couple. So one mother reports, the nurse said, "What are your thoughts? Do you want to do medication? Do you want us to call the doctor?" And I said, "No." I said, "Let me stand up, let me just gently rock her, and let me have a couple minutes." And they were concerned, like, "Are you getting stressed? Do you feel anxious or scared?" Because those are legitimate questions, especially when a baby is crying. And I was able to calm her down. And then I'll just read one more. Before, like I said, they put my daughter, this is from a previous delivery prior to CHoSEN, on methadone. She was in the hospital for 2.5 months. And now this time, it was only 5 days. She didn't have too many withdrawals. They explained why they go through the withdrawals, because I never understood that either. We felt a lot better about everything. So I think what these quotes highlight is not only sort of all the kind of medical, hospital level kind of data that I shared around length of stay and farm treatment, but really the family experience and how families are feeling more engaged during the birth hospitalization. They feel included and they feel valued. And I think these quotes really get at that in a much more effective way than our quantitative data.